Hello, and welcome to another episode of Boundless Body Radio. I'm your host, Casey Ruff, and today we have another amazing guest to introduce to you now. Dr. Paul Kolodzik is a double board-certified emergency and metabolic health physician with 30 years of experience. As a private practice metabolic MD, Dr. Kolodzik has used continuous glucose monitoring, also known as CGMs, to help thousands of patients lose weight and prevent and reverse disease. In his first book, The Continuous Glucose Monitor Revolution, Lose Weight, Look Great, and Live Longer with continuous glucose monitoring, Dr. Kolodzik presents a comprehensive program for metabolic health success using a CGM. In the Continuous Glucose Monitoring Revolution, Dr. Kolodzik also reveals how CGM devices can help reverse chronic disease, prevent future sickness, and lengthen lifespan, all by measuring and managing the right data. Whether you're just now learning about CGM for the first time, or you're ready to try one, the Continuous Glucose Monitoring Revolution will help you make an informed decision, take control of your future, and easily turn health choices into habits. Learn more at www.metabolicmds.com or on all social media outlets, including on Twitter at dr.kollo.md. Dr. Kolodzik, what an absolute honor it is to welcome you to Boundless Body Radio.
Great to be here. Thanks for having me.
It's such an honor to host you. You were kind enough to send me a copy of your book, which I really, really enjoy. It's very understandable. You get into the science, but present it in a way that is easy for dummies like me to really be able to understand it. And when I look through all the people that wrote in wonderful references on your book, you know, Dr. Philip Ovadia, Dr. Cucuzella, all these, Dr. Tro, Brian Lenskis, all of my friends and people that we love in this low-carb community. If they say your book is good, I think your book's going to be good.
Yeah, I'm standing on the shoulders of giants in that regard. So,
well, it's so awesome.
Yeah.
I can't wait to dig into a lot of these topics that we share a common kind of passion for and everything. But I did notice the Notre Dame football in the back there. Obviously, you did go to Notre Dame, correct?
Yeah, I did my undergrad there.
That's amazing.
Yeah.
What was that experience like?
Oh, it was great. I mean, I'm fortunate. I'm blessed. A lot of good friends still there. We have the football team to rally around and get together for tailgaters once or twice a year. Some years are better than other years, of course, but there's always that optimism about the future.
Yeah, I was going to say, you've had some bad years, but not very many. I think they're kind of few and far between at this point.
Yeah. And we played Utah a few times, BYU a few times. So, it's great to go to those games. I've actually went to the Utah Stadium. I haven't been to the BYU Stadium.
Oh, that's okay. You don't need to spend too much time in the team down south. Like, stay up in the Utah crowd. We're more fun anyway.
All right. That's what I hear. I'm told that.
Yeah,
so.
You don't need to mess around with those guys down south unless you're going to go visit Ben Bickman. That's the only excuse you have to go down to the valley down south, as we call it. But yeah, otherwise no reason.
I just came from the Low Carb USA conference in Boca in Florida. Bickman is brilliant. Yeah, he is so enjoyable to listen to and so insightful. So if your listeners haven't looked up Ben Bickman, they need to do that.
Man, I'm so sad that I missed that conference. When I was thinking about planning for that conference, it was so time prohibitive to get out down to Florida. And I kept thinking, like, you know what, like Low Carb Denver is coming up. That's normally in February. And so I didn't sign up for the conference and then learned that they were not doing Low Carb Denver 2024. I was devastated, man. No.
Wow.
Well, yeah, Dr. Gerber, I saw a message from him on social media that said something like he needed a break, which I totally understand. Those things are so difficult to organize, but I have to say it is heartbreaking and devastating. You probably could have done a few good turns with Dr. Gerber. I think he takes a lot of his speakers up to the slopes after the conference.
Yeah, good. But just Low Carb USA, Doug Reynolds puts it on. He does a great job. And there's one in San Diego sometime in the fall, too.
Yeah, I went to that one in 2023, and it was so wonderful. I signed up on the spot to go back in 2024. Doug's the best. He does a great job putting on those shows. He does a great job keeping people from asking personal questions when it's Q&A time. It's my favorite part. But yeah, Dr. Bickman, from what I heard about his presentation, obviously, always it was going to be amazing. But I heard that his PowerPoint presentation in particular was amazing. Like so well put together.
I mean, and he brings things down to a level that we can all understand. This year, he talked about number of adipocytes and their size and how that is affected by diet. He did a great job.
Wow. I love that guy. We're going to have him back on here in a few weeks. I'm so excited for that. But for right now, we're talking about you, my friend. Tell us a little bit about your interest in health, how you decided to become a medical doctor, and how that kind of shifted as the years went on.
Yeah, so I guess the most significant backstory for me is that I've spent 25 years in the emergency department. You see a lot of things in the emergency department, the gunshot wounds, the overdoses, the multiple traumas, and that's what gets all the press. But really, what emergency physicians see day in and day out, and which I saw for an entire career, is the vascular issues, the blood vessel issues, and the issues caused by obesity. So it is, our bread and butter. It's heart attacks and strokes and peripheral vascular disease and kidney failure from diabetes. And I realized after many years that really a lot of these problems are preventable if people just have the knowledge base to understand how to prevent them. Basically, it comes down to controlling your blood sugar and making sure it's moderately low and stable. And so about 5 years ago, I decided to get out in front of that, opened my own metabolic health clinic here in Ohio. And we've been helping people reverse the disease and lose weight since that time.
Wow. It sounds to me like that's quite a big and brave kind of leap. Was it really difficult to commit to that?
You know what? When you're passionate about something, it's not that hard. Early on, new practice, there's always trials and tribulations. This is a concept whose time has come. You know that. We were told back in the 1970s. I remember this. You probably don't. But we were told that we ate way too much fat, and that low carb, excuse me, that carbs were the way to go. So almost overnight, our diet, when the food pyramid came out, went from 25% carbs to 50% carbs, and from 50% carbs to 25% fat. And we were told butter and meats were bad for us, and we needed to eat vegetable oils all the time. And the epidemics of obesity and diabetes took off after that, predictably. The food pyramid came out in the early 70s. 10 years later, the epidemic of obesity takes off. And then 10 years after that, as expected, once you get overweight, then you get insulin resistance. The epidemic of diabetes took off. So, really, yeah, I think, low carb diets or even carnivore diets are not that radical. We're really just going back to the way we ate for many, many years before, we were told by Dr. Keyes and the USDA that we should eat more carbs.
Yeah, it certainly impacted my life growing up as my mom was sick with cancer. We changed our diet and got the white bread out and the wheat bread came in and the skim milk came in. And I remember we could eat all the licorice we wanted and fruit snacks and obviously didn't go great for her. But that was the advice that we were given. And we were just doing the best we can, as everybody was. And it's interesting to contemplate kind of what you were saying. You see the one and then you see the next and you see the next and then diabetes and all these things kind of happen earlier and earlier and earlier and on a time scale. And now it's quite interesting as you're seeing this next generation come up in it, that like now you're being affected by what your parents ate for all those decades and what it was like in the womb and growing up. I mean, we were just on a plane yesterday with this little kid, maybe 2 years old, that was, drinking a Coke and watching YouTube videos play over and over and eating a big donut. And it's like, that's not great.
People don't know. People don't understand. And a lot of people pass. It's not entirely their fault because we're told by everybody. We're told by the medical establishment. We're told by the pharmaceutical companies. We're told by the food processing industry that we should be following this path, and it's just wrong. It's profit motivated. It's not motivated by trying to keep people in good health.
Yeah, I completely agree. And we do love the carnivore diet around here. It's something I've done for almost 5 years, and we help people if that's what they want to do. But I would strongly submit that if we could have just continued the way we were going, we probably would never even get to a place where we need to recommend carnivore diets. We could have been just fine eating seasonally fruits and vegetables that would have been available most of the year. Other foods would have been available like animal foods, and we probably would never have a problem.
Yeah, I agree. But our diet were changed. We were influenced, and I think there's now a core group of people, you included, that really are trying to get out there and educate people. and keep them healthy for a lifetime.
Well, yeah, and so grateful for you for doing the same thing, having that passion inside enough for you to make a complete change in how you were working with people. Again, to me that's a scary thing, but it's like you said, if you're passionate, it'll push you towards those things. I want to talk about some of those diseases that you mentioned and those chronic diseases. I'm sure you were never taught that they were reversible. What is the best model that we think right now? Obviously we don't know everything and things are changing all the time, but what's the best model we have that leads to all of that chronic disease, starting with gaining weight?
Yeah. So the issue for the majority of middle-aged Americans, and most of my practice is metabolic syndrome patients. Those are patients that are overweight, increased abdominal girth, hypertension, high cholesterol. And the way the majority of middle-aged Americans got there, even young Americans now, is insulin resistance. And I assume that you've probably talked about on your show insulin resistance quite a bit, but it's really a critical concept. And if it's okay, I'd like to kind of distill it down to the way I think about it and the way I explain it to my patients.
We have had
Okay.
insulin explained 100 times on this show, and I am a very, very slow learner, and I love everybody's nuance and how they explain it. So yes, please, you have an awesome analogy that I've heard. Yes, please explain how insulin resistant works.
So, I try and keep things simple. I'm not like an academician or a researcher like Dr. Bickman. Emergency physicians have a tendency to be just pragmatic. It's like there's a problem that comes in. How do we solve that problem? Move on to the next person. The way I look at this fairly simply is, it's amazing the number of people, even with prediabetes or diabetes, don't understand that when you eat carb, it becomes blood glucose in your system almost immediately. A little bit of fructose, but mostly blood glucose. So the way I look at this and the way I explain it to my patients is you eat a carb, your blood glucose goes up. What happens after that? Well, something has to happen to that blood glucose. So your pancreas releases insulin and it drives that blood glucose into your organs. And the easiest organ to think about is your muscles. Just think that, okay, blood glucose goes up, insulin gets released, that blood glucose is being driven into the muscles. But what happens if you're eating carbs frequently? Well, the blood glucose stays high for a persistent period of time. And after a while, those muscles say, we got plenty of energy here. There's plenty of blood glucose in the blood. We've already stored some blood glucose in our system because there was so much around as glycogen, which is just a complex glucose molecule inside the muscles. And after a while, those organs just start saying, stop. We are not going to listen to you any more insulin. So the pancreas doesn't get the message. The pancreas keeps pumping out insulin, and the insulin level keeps going up. But the organs are saying, we aren't listening to insulin anymore. So what happens with that extra blood glucose? It has to go somewhere, or you'll die because of that. So it goes to the liver and it gets converted to fat, and then it gets deposited around the middle. So we've been taught that eating too much fat causes people to be overweight. That's not the issue in the majority of Americans. It's eating too many carbs. Too many carbs cause fatty liver disease. Now, people don't, normally understand that, but it is the conversion from the high blood glucose to fat in the liver that causes that fatty liver disease and then causes the deposition of fat around the middle. So how do you reverse that? Well, you try and decrease the carb intake. You lower the carb intake. Carnivore, keto. I have a lot of patients that are just low carb. And then what happens? Well, those organs who prefer blood glucose start looking around and saying, hey, we need more energy here. There's not been as much blood glucose. You haven't been eating as many carbs. So they start looking around for blood glucose, but there's not as much around. So then what do? They say, we need energy. And so what do? They look down at the middle. They look down at that adipose fat around the middle and say, that's going to be our energy source now. And you start breaking down those fatty acids around the middle to supply energy. And that's when you lose weight. A byproduct of breaking down fatty acids can be ketones. So that's where the keto diet gets its name. So that's really it, from a simple perspective. And I think the analogy you were probably alluding to is the bear that's fattening up in the winter. So it's out foraging on berries and roots, and it's fattening up. and it's laying down all this adipose tissue because blood glucose has gone up, extra blood glucose has gone to the liver and created fat. But then the bear goes and sleeps for 5 months and doesn't eat anything and lives off that adipose, is in, ketosis the majority of the time. We don't do that. We keep going to the grocery store, and keep buying food, buying carbs a lot of the times. So what we're really trying to do is just emulate the bear that comes out in the springtime after having lost all that weight because it survived on fat over the period of time. And that, in essence, from my perspective, is really just what a low carb keto carnivore diet is.
Beautiful, man. Beautiful explanation. I absolutely love that. I spent a better part of my career in a corporate gym, and we were doing metabolic testing. So I was working on a metabolic cart, and we would show people how they were oxidizing not only total calories, but the split between the calories coming from fat and the calories coming from carbohydrates. So we'd use that a lot to, you'll appreciate this, tell people not to do nearly as much cardio as they think they needed to do to be fit and healthy. I think you might be on board with that. We'll talk about that later.
Absolutely.
But also we had a graph, and the graph would show a person and whether the person, it would show you fat and it would show you carbohydrates. And this was a storage graph. And whether you were a male or a female, the number for carbohydrate storage would be either 1,500 for females, 2,000 for males. Obviously, that would be a little bit different based on what you mentioned, which is muscle mass. And we would explain that as like, this is the upper limit of the number of carbohydrates available that you can store. And then we would show the number of fat calories that they had on their body. And this was an extrapolated number based on their weight and their body fat percentage. So you had a maximum of 2,000 in the carbohydrate, and then you had a number that could be tens of thousands, 100,000, 200,000. For people that were really big, it might be 500,000 calories of fat energy in the body.
Right.
And people are like blown away looking at that number. And it's like, if you exceed this storage capacity of carbohydrates, which is very, very, very small, everything gets pushed over into the fat tissue, and it is seemingly endless in its ability to add on more and more and more.
Yeah.
That's the system.
Yeah. Yeah, actually, that's great. That's exactly in parallel with what I just talked about. So that's analyze people in the lab, and we're able to show them exactly what was going on. That's great.
It's boggling to think that it's not fat that does that. It's carbohydrate that gets into the liver and gets transferred into triglycerides because it's in the blood where it shouldn't be. It has to be stored away. So again, I love that explanation. And now we get to kind of the monitoring side of things. And we all know people that are diabetic that like to stick their fingers to measure what their blood sugar is at any given moment. And that's fine. A lot of people do that daily. Can you tell us about the pros and cons of testing our blood glucose?
Now, I think knowing your blood glucose, along with knowing your fasting insulin level, which I'm sure we'll talk about, is absolutely critical. And yeah, you can get an idea of what's going on with a stick periodically. But having continuous glucose data at your fingertips 24/7, I'll go out on a limb here and I'll say for some people, seeing that for the first time can be life changing. We have primary care docs that are in their offices and they're talking to people about what their blood sugar is and how it needs to be controlled. And I've had people that have talked to their doc for years about that. And then sometimes the primary care docs now refer patients to me. They come in and we put a continuous glucose monitor on them for 2 weeks. So for those, your readers, I think most of them know what a CGM is, but it basically is one of those devices on the back of diabetics' arms you see sometimes. Now more and more non-diabetics are using it. And it gives you a 24/7 glucose reading. So you can see, when your glucose peaks, when it drops, how stable it is, what your averages are. So I use the CGMs, first of all, in a diagnostic phase where I ask people to come in, we put a CGM on, they can follow the numbers on the app on their phone, and tell them not to change their diet. Don't do anything for 2 weeks. Let's see where you live. And many of them don't realize they're pre-diabetic and they're diabetic. I have some people that don't realize they have any blood sugar problem and they're actually diabetic. But once they see those graphs on their phone, and I'm sure you've seen this, yourself, I would assume you've probably worn a CGM in the past, right?
That's funny.
Yeah.
I actually haven't. They sent me one and I still haven't put it on, man. I need to stop resisting it to do it.
Yeah, you need to do it. Just whatever your diet is, keep doing what you're doing. But the way my patients have put it, once they see those numbers, those rises, those falls, the variability, which can cause brain fog and zap your energy. The way they put it is they can't unsee it. Once I've seen that, I can't unsee it. And quite honestly, it can be life changing for some people. They just realize for the first time the light bulb goes off and they understand what metabolically, physiologically has been going on in their body. And then they graduate from that to leveling those numbers out. And they realize they feel so much better in terms of energy, brain fog, weight loss progresses. It can be really amazing. So that's why I became such an advocate of CGMs and, wrote the book about it.
Yeah, you certainly did. And one of the chapters in your book is about how the CGM tends to be self-correcting for a lot of people. And I've certainly noticed that, at least in the low carbohydrate space. I've talked about this woman before. I ran into a woman while we were on vacation in Mexico a few months ago, and she had a CGM, and it was easy to see, obviously. And so I just walked up to her and said, "Hey, do you have a CGM?" She said, "Yes." I asked her if she liked it. She said, "Yes," because she didn't need to stick her finger like she was before. And she really just focused on the sticking your finger thing, which I appreciate and I like. But based on, she opened up the app and she showed me her curves, and they weren't flat. They were up and down and up and down. Her blood sugar was very high. So to me, it was apparent that she had gotten the CGM, but still had nothing self-corrected just yet. Possibly it was because she was on vacation and relaxing a little bit. But do you see a lot of people like that it really doesn't help them self-correct?
So most of my patients, let's make a distinction here. CGMs were created for diabetics to help dose their insulin. That was their original use. So I'm using them in some diabetics, but really more frequently in non-diabetics and pre-diabetics. So I will say that I have a selected population. People come to me because they want to lose weight and they want to know what those numbers are. So they do have a tendency to pay pretty close attention to them.
That's a fair point.
Yeah. And then the other very critical thing that we do during the initial evaluation is a fasting insulin level. Fasting insulin levels are absolutely critical. I'm going to give you my bias. I think they're more critical for most overweight middle-aged Americans than their cholesterol level is. I think, we focused, for 30 years now, 40 years on cholesterol and the use of statins, when the reason for a lot of vascular inflammation, blood vessel inflammation for most people is not caused by high cholesterol. It's persistent high level of blood glucose. That leads to the problems I talked about at the beginning, the strokes and the heart attacks and the peripheral vascular disease and the kidney disease. So those glucose molecules attach to your blood vessel linings. The kind of the party line in medicine is anytime your blood sugar is above 140, you're getting a little bit of that vascular inflammation. And so I think knowing, following those blood sugars is important, but the reason the blood sugars may be up is because of the insulin resistance issue that we reviewed. So I do a fasting insulin level on every patient that comes into me. And there's a minority that don't have that insulin resistance. But again, because my patient population is selected to come into me because they're overweight or have an issue, the majority do. And knowing your exact level of insulin resistance is critical. You draw a fasting insulin level, and then you draw a simultaneous fasting blood glucose. Because think about what we just talked about. If your insulin level's up, it should be forcing that blood glucose into your organs and dropping your blood glucose. But if your insulin level is up and your blood glucose is not as low as it should be, you've got insulin resistance. So you plug those two numbers into a formula called I don't want to get too wonky here, but it's called a homeostatic model of insulin resistance. The acronym is HOMA-IR. And you can calculate an exact level of insulin resistance, and then you can follow that along. People change their diet. You can recheck it again in 3 or 4 months, and you can know exactly what's going on with your level of insulin resistance. This can be one of the keys to reversing prediabetes as well.
Wow. So important to have both of those numbers. Do you ever just sit and in awe of all the wonderful things our bodies can do and how much it protects us from these threats? And it can do it chronically for so many years before we break down. You mentioned 140 as far as the level of blood sugar in the blood. A normal level is 80. That's 1 teaspoon of 5 liters of blood, a tiny, tiny amount. You increase that by almost just a little bit more than half, and you're causing problems. It's crazy.
Yeah.
And the body tries
Yeah.
as hard as it can.
Yeah, they try to protect us, and insulin resistance can be going on. A lot of researchers like Dr. Bickman, they believe insulin resistance is present. It could be present 5 or 7 years, even before you're pre-diabetic. And so, in my mind, if you're tending toward prediabetes, unfortunately, we want to talk about this a little bit. The model of American medicine now, unfortunately, it's different. I'm going to make a little bit of a offer an opinion here, a little bit of a political statement. But so when I got out of school, most docs were is still working in their own primary care offices. It's just hanging out a shingle or a small group. And now, unfortunately, most medical providers work for large systems. Yeah, that offers certain advantages, but I think it offers some disadvantages as well because now the medical providers and a lot of your listeners have experienced this. You go in to see your doc once or twice a year, and you might only get 20 minutes with them. They're kind of relegated at times to just disease management. What's going on with your blood pressure? Do we need to adjust your medicine? Oh, your blood sugar's a little bit high. We'll keep an eye on that. In my mind, if your blood sugar is a little bit high, lights and sirens should be going off. I mean, that's an emergency because you're pre-diabetic. Well, that's the doctor telling you you're pre-diabetic or pretty close to pre-diabetic. And pre-diabetes is reversible. Now, you can get into this argument whether diabetes is reversible or not. I'm kind of in the opinion that diabetes can be put in remission, but not necessarily completely reversed. So I kind of like, I hedged my bets there with the term remission. But pre-diabetes can be completely reversed so that you never go on to be diabetic following, the program and the things that we talked about and that we're probably going to talk about. So I just think that's a very, very critical time. And unfortunately, as we talked about, the healthcare system, the pharmaceutical system, and the food processing industry isn't friendly to helping people figure that out.
Yeah, it seems to be so hard for people to get an insulin test to begin with. Doctors are not really cued into that, but it's like you explained with the insulin numbers. You need to know both because the insulin can be climbing and still controlling the blood glucose, which will look fine. And it's hilarious, like you said. Like, let's just send people off on their ways. Just continue doing what you're doing. You have the pre part of the disease. Let's just wait until you get the disease, and then we can deal with it. Like, are you kidding? Like, really? That's the best we can do. That's the best we can do.
Yeah, well, it's not the best we can do. We can do a lot better,
Yeah.
and I get that satisfaction with people that come in, completely reverse their pre-diabetes. I have a lot of people that come in and it's like, I want to lose some weight. And it's like, okay, we can do that. But then they realize that the issue is much bigger when they find out they're pre-diabetic or even diabetic. So yeah, we have an approach that we can reverse those problems. Um, then I move people on from a diagnostic phase into kind of the therapeutic phase. And you alluded to some of the things that we're going to talk about a little bit. Can I maybe share with your
Please.
listeners kind of what my program is?
Yeah, absolutely.
Okay. So I usually then, my entire program is always low carb. Now some people can jump into that and, go under 50 grams. Some want to go carnivore, some want to go keto. Most of my patients actually have never pursued a low carb diet. And so I need to kind of move them into that somewhat gradually. By somewhat gradually, it's like, I have them target 75 or 50 grams of carbs a day or less. 75, I think, is still pretty high. But for people that have been eating 350 grams a day, you got to acclimate them a little bit. And it's very important that they count those numbers. I make them use an app, Chronometer, My Fitness Pal, yeah, Carb Manager, whatever they want to use, but they have to meticulously count their carbs. And I care about their carbs and I care about their protein. I want them to push their protein because they're going to get into strength training, importantly, as we'll talk about. And I really de-emphasize fat. It's like I don't care about your fat that much. Get what in the big scheme of things. I want you eating good fats. Hopefully you'll be not eating seed oils. We'll educate you about all that. We'll talk about good saturated fats. We'll talk about the omega 3s versus the omega 6s. But I don't care. I actually don't even ask them to count their grams of fat. I just want their carbs low and their protein high.
That's perfect. And I love in the book how you talk about, like, generally speaking, these are some good foods, accepted foods. These are some not so accepted foods. And one of the cool things is we can use that as a starting point to say, let's start here and eat these foods. But a continuous glucose monitor will tell you whether those foods actually work. The number of times I've heard people say, you know what, actually, like, carrots had way more sugar than I thought, and they were spiking my blood sugar. I would not tell people to avoid carrots. You know what I mean? Like, if somebody said,
Yeah.
I love carrots and I'm eating a relatively low carb diet, I'd be happy with that. But the continuous glucose monitoring will tell you, are bananas okay? Does a potato work okay? Maybe it works for a lot of people, but maybe not for you.
Yeah, and it's individualized. Different people respond to different foods in different ways. So there is an individual profile there. And since you were talking a little bit about fruits and vegetables there, I'll put in my 2 cents worth. Obviously, with vegetables, we try and go with the high fiber vegetables. With fruits anymore, you got to be careful. Your mom told you to eat all your fruits and vegetables, but the fruits are genetically engineered. It's different than it was 50 years ago when I was growing up. Your fruits now are genetically engineered for high fructose content to taste good, to sell more fruit. And so you got to be very careful. So I have people, for example, pineapple can just be packed with fructose. Bananas can be packed with a lot of sugar as well. I steer people toward berries. They have a tendency to have more fiber and a lower fructose content. So strawberries, blueberries, raspberries, blackberries is the direction I kind of head people. But it's not the blanket eat all your fruit and vegetables the way it used to be.
Thank you very much. I think people are so used to seeing softball size apples in a cellophane container at Costco where they can buy them 365 days out of the year. They don't see the apple tree growing in nature that has these, pretty tiny and pretty tart apples that you can get for like a month and a half. Kind of different.
That's perfect. Yeah, the size and the sweetness. I mean, it's a different ball game than it was, 50 years ago, or many generations before, when, for example, those were the only kind of apples that were available.
Yeah, absolutely.
So,
Really great point.
yeah.
We're talking about eating here. We could also talk about not eating and fasting. How have you found fasting to be a beneficial part of your program?
Yeah, so the most effective tool for lowering insulin resistance, other than just a low carb diet, is fasting. And I'm a big proponent of intermittent fasting. Again, most of my patients are regular people. A lot of them haven't, fasted before. Again, middle-aged, metabolic syndrome people. So I don't, if you'll excuse the expression, I don't try and solve world hunger with them with fasting immediately. If they never fasted before, it's like, okay, let's do 10 hours overnight, and then let's make that 12 hours. And then let's see eventually if we can start pushing breakfast back, and maybe just make it an early lunch. So even now, most of my patients, intermittent fasting is a 14 or a 16-hour fast. Some of them do OMAD, one meal a day, which is generally what I do. And some of them will push it with a 24 or 36-hour fast periodically. But you don't have to. My perspective is you don't have to fast for 3 days to get the job done. You just have to be depriving yourself of primarily carbs for a period of 14 or 16 hours, and that'll help you get the job done.
Yeah, I agree with you. I think anything inside of 24 hours, 36 hours you mentioned is generally safe for most people. I have more questions when people start pushing it on, and people can do it, but I have more questions when they do it. So I like to live in that kind of level as well. You write about basal metabolic rate, which I love to talk about. Like I said, I had lots of experience on a metabolic cart, and that was the thing that actually brought me to low carb to begin with. People that were doing fasting, so they weren't eating very many calories, which we knew would drop their metabolic rate, but their metabolic rates were going bananas, gangbusters, like way higher than even a normal metabolic rate should have been for them. They were burning 500, 600, 700 calories higher if they were doing fasting. Why is it that fasting is different than just depleting calories?
Yeah, I'm going to be honest with you. I don't know exactly how to answer that question, but I will tell you that I believe that the energy balance model of trying to lose weight, the calories in, calories out model, which, we have followed, over the course of, many, many years, isn't effective, and in particular is not sustainable. You can't do that for a lifetime. The great thing about carnivore and keto, low carb, is you can always eat something. I say that to my patients. You can always eat something. I might not be wanting to eat something with a lot of carbs in it, but if you're hungry, go eat something. So the best approach I think is not trying to balance those calories, and it will help with your metabolic rate, as you mentioned. The other thing, which is the third piece of the stool here for my patients in terms of their program, is we talked about low carb or keto or carnivore. We talked about intermittent fasting. You brought up basal metabolic rate, so let's talk about strength training. What you want to do is, as best you can, increase your muscle mass, because that will increase your basal metabolic rate. And what does that is strength training. Going into the gym and running on the cardio machine for an hour and a half doesn't do that. You've got to build muscle mass, which is critical for a number of reasons. One is, again, I'm not a calories in, calories out guy, but it will help your basal metabolic rate a bit. The other thing that's really important, and I don't know if you've had a chance to talk about this, is that when you increase your muscle mass, you increase the quality and the receptivity of the insulin receptors on your muscles. So you soak up more insulin. You're basically reducing your insulin resistance by increasing your muscle mass. And that can contribute significantly to reducing insulin resistance. And then, part of this as well is that, as we get older, we're losing at least 7%. You probably know the numbers better than me. 7% of our muscle mass a decade. Some people say a lot more than that. And so strength training has got to take a priority. So I don't completely disbelieve in cardiovascular training. I tell my patients to follow the American Heart Association guidelines for cardiovascular fitness, which basically means if you can get your heart rate to 80% of your max and you do that for 75 minutes a week, the clock doesn't start till you're up at that rate, but 80% of your heart rate max, you do that for 75 minutes a week, then, you can spend the rest of your 4 or 5 hours working out a week. I know for you, it's a lot more than that, Casey, but, for most people, it's like, they're going to have 3 to 5 hours a week to work out. And I want them spending it doing weights. And I don't care if it's bands. I don't care if it's free weights. I don't care if it's machines. I don't care if it's body weight. I don't care if it's Pilates. It's got to be some kind of resistance training. Much, much more important as we age than cardiovascular training.
Yeah, that was an amazing answer to the original question. First of all, that you transition fasting over to strength training and tied it in with basal metabolic rate is wonderful. It's tempting because we look at the cardio section and there's a calorie counter there, and I can burn 500 calories if I run and sweat my brains out for a certain amount of time. The chest press machine doesn't have a calorie counter, so I'm going to have a tendency to go over towards the treadmill. But we forget about the after effects of strength training. It's so critical to do any kind of strength training. And I gotta reveal myself here and let my secret out to all our listeners. What you said about me working out very much, dude, it's maybe like an hour a week of resistance training. Now it sucks. It's really hard and very intense. And it might just be like what I just did. Like, it's really cold day here in Salt Lake City. So I went to my community center. I did some walking and just kind of walked around the track. And then every 5 or 6 laps, I would do a set of strength training, but it's hard, really to shaking, almost to failure.
Yeah.
And that's what you want, that strength training. So the good news is, yes, if you love to strength train, by all means, 4 or 5 hours a week, you can, but you can do it with a lot less as well. It's awesome.
Yeah. Yeah. Yeah, it's great. And getting to failure is great. But again, I mean, I have a lot of women that come into my practice and, they've never lifted a weight in their life. And it's like, let's just get started. Here's a set of bands. Let's talk about, I got a, trainer that works with me, health coach. And let's talk about, starting just 20 minutes 3 times a week and going from there. And I just want to get people started. I can tell you a story. I had one of those ladies who never lifted before. And so she's with me with about 4 months. She did really well. She bought into the whole program. And she comes into my office for her next appointment and she says, "You know what? This morning I was brushing my hair in the mirror and I saw a bicep." I had
Yes.
never seen a bicep on myself before. And she was just tickled to death. And she went on and did great, changed her body composition. It was great.
That's
So,
awesome. Yeah. Thank you for
yeah.
clarifying that point. I don't want anybody to feel intimidated if you've never done lifting and we're talking about like lifting to failure. It's lifting
Yeah.
to fatigue. It's like doing something until you're a little bit tired.
Right.
And you're right about bands.
Yeah.
Like if you have a gym membership, awesome. Go use the machines. They're safe. You could go to Amazon right now for $30 and buy a set of 4 bands of different
Yeah.
intensities and do like 6 different movements. You could do it from your bed. It is
Yeah.
accessible. If you want to do this, you can do it, and that will be maximally beneficial.
Yeah, yeah, we give our patients all a set of bands if they, are not already going to the gym.
Yeah,
So,
perfect.
and then the piece which, I think most of your listeners probably know about that's critical with this, it's critical with men and women, but related to muscle mass, it's the osteoporosis issue too. The old saying is that if it doesn't kill you, it'll make you stronger is true related to your not only your muscles, but your bones. Your muscles and your tendons will put stress on your bones. That will keep your bones with a higher calcium content, and that will help you avoid osteoporosis as you age. So, another reason, in my mind, strength training trumps cardiovascular
I
fitness.
love that. Dr. Doug McGuff and John Little do a really good job in their book, Body by Science, kind of explaining some of these concepts and really goes in depth about how we even got to call that type of exercise cardio or where the word aerobics came from or why we think it's heart protective. And it's not as much as you think. They call the guy who came up with the word, I think they called him like the savior of American hearts. And Doug McGuff makes the point, like, you might have been the guy who like destroyed the most knees in America. Like thinking about like jogging, if you went back to like the 60s and saw somebody jogging down the street, you'd probably run too because something bad was probably happened. We weren't like going out and quote unquote like exercising and quote unquote doing cardio the way we think of it today. We were just like moving
Yeah,
around and sometimes we'd have to lift heavy stuff. And so it's a totally
yeah,
different context. And there's some really interesting research out there to say that like you can get every bit as much of the cardiovascular benefit you think you're getting from jogging all the time, from lifting weights and strength training in the proper way. So I love that you talk about
yeah.
that. I'm totally on board with all of that.
Yeah, absolutely. So again, that's the best version. I do some TikToks, and I did one that the one that got the most views was get off the expletive cardio machines. And I go on to explain just what we talked about. I don't mean completely ignore cardio, but spend most of your time in the weight room. And I got a bunch of views for that. So,
That's great. I'm way too old to be on TikTok, but I did see that one in prep for this conversation. You did a great job. It was awesome. Any other
all right,
lifestyle
thanks.
factors that are important in what we're talking about? Like, you hear the sleep and the stress management and the cold plunges are really
Yeah.
popular now. Is there anything else that you think is kind of a major lifestyle factor here?
Yeah, I don't know a lot about the cold plunges. The stress and the associated cortisol release is big. I have patients that have difficulty when they're going through, family issues, work issues, whatever. Before I got on with you today, I had a patient. This is just, and I just identified with this lady. Same company for 30 years, got laid off last week.
Mm,
And the stress that that's going to cause, and I'm worried about, the body's response is to protect itself, and it protects itself with cortisol and adrenaline releases. And so I worry about the stress and trying to manage that. I'm a big believer in cognitive behavioral therapy, CBT, which is basically just finding a therapist or therapist to sit down and talk with, and allowing you to verbalize what's going on in your life. I think that can be very stress reducing. But we manage stress, and sleep is obviously also important. There's two sides to that. One is making sure you dedicate enough time to sleep, and then the other is being able to sleep once you lay down.
yeah.
So, we work on that with patients and different relaxation techniques.
That's great. Yeah, getting outside and getting some sunlight during the day to help set circadian rhythm. Yeah, and
Yeah,
you mentioned the stress response. I see that all the time as well, and it's amazing. When we're talking about mental health, all the research that's coming out about low carbohydrate diets and how ketones affect our mental health. Hopefully, that's helping with a stress response. That's really the kind of primary reason that I stayed on carnivore after a 30-day trial is that my anxiety was just so much better, my mental clarity was so much better, that brain fog frog you mentioned earlier in the episode just kind of went away. And so, hopefully if people are implementing diets, that will be a great adjunct to all the different therapy options that you mentioned as well. And all of it can really help. So I love that.
Absolutely.
Yeah. Okay.
Yeah.
Well, we've been talking about lifestyle and changing that and talking about diet and exercise. I got to tell you, man, this stuff is hard. Donuts taste really good. Going to the gym takes a lot of time. If we could come up with a pill or an injection that could help us with weight management and some of these things you're talking about, that would be great. Oh, wait, I just heard about one. Oprah's taking it. All the stars are taking it. They're losing tons of weight. I would love to talk to you about this topic.
Yeah.
I think it's really easy to get into this world of low carbohydrate and carnivore diets and think this is the cure all. This is going to fix
Yeah.
everything. You don't need to do anything else. Pharmaceuticals suck. There's no room for them anywhere. And I'm not quite ready to say that. And you have a really interesting and nuanced way about looking at some of these different drugs. We could be talking about Ozempic and semaglutides and all these trendy words and drugs that we see advertised all the time. Tell us a little bit about the new development, this latest wave of drugs that seem to be extremely popular.
So it's first of all, the environment right now is that it's the Wild West out there in terms of these medicines being prescribed. Easily accessible on the internet, not, I think, a lot of thought or effort put into the medical evaluations. These medicines should not be used without a comprehensive program like we have been talking about over the last hour. I think low carb strength training in particular, because you lose muscle mass on these medicines. I do believe the genie is out of the bottle, and that these medicines are going to be used. The drug companies are going back now and trying to find whatever indication for them that they can. Oh, it's going to lower cardiovascular disease. Oh, it's going to treat fatty liver disease. And I can't really completely disparage the medications because I'll be honest with you. I think this is a very positive development in pharmaceuticals for some people. The problem is that they need to be used very limitedly and very judiciously. Because kind of the standard right now is, again, we're just going to throw medicine at the problem. People come to me and it's like, hey, we're going to do lifestyle things before we even talk about any medications. I do use the medications. Let's give a little bit of background on them. They're once weekly injection. We're talking about Manjaro and Zepbound and Tirzepatide and semaglutide and Wegovy and Ozempic. They're all in the same class called GLP-1s. They work three ways. They slow gastric emptying, so they keep your stomach fuller for a longer period of time. They lower blood sugar, which we just talked about. Originally, they were used in diabetics, and they were found to lower blood sugar but not cause hypoglycemia or low blood sugar. So people lower their blood sugar, they're burning a little bit more fat, and then it has a direct effect on the brain and the hypothalamus to decrease hunger. Um, I think that consideration, if diet and exercise does not get a person where they want to be, a consideration of very limited temporary use of these medicines may be appropriate in some patients. Now, unfortunately, what's happening right now out there is it's like people are getting prescribed medicine and not as part of a program. They're just like, here's the medicine, good luck losing weight. And the downsides of this medication are the loss of muscle mass and the weight regain if and when you go off the medicines. And I don't feel it's appropriate to start a medicine on some people that's not, a critical medicine, a life-saving medicine. Start a medicine on somebody, you could say maybe for vanity reasons, it's being taken that way a lot of times, not just for metabolic health. And then because they are not doing the other things, commit them to lifelong dependence on this medicine. So the way I use it is I usually don't start it right out of the box, right out of the gate. I usually start it if a patient has a stall, and I sprinkle in small doses for limited periods of time to help them get through a plateau or move on. Now, I have some mixed feelings about this, but I'm trying to capture a patient population where I can influence them with the low carb, with the intermittent fasting, with the strength training, and quite honestly, try to save them from going down that road where they're only doing medicine. Because there's only a limited number of practitioners out there like me that are using these medications in a prudent manner. Um, I think they're good medicines. I think this is just a prediction. I think they're going to become the most prescribed medicines in the history of the world. I know that's a mouthful. I think previously that has been statins, but again, the genie's out of the bottle, and I think that these medicines will do good for a lot of people for a variety of indications. But it's really incumbent on both patient and medical provider to commit to using them prudently.
Wow. Statins, you should be on your toes, man. Statins, we're coming after you. That's crazy.
Yeah.
That's a boggling thought, knowing how big the statin industry is, that I agree with you. It might be a scary short amount of time that that's the case.
Yeah.
Hmm.
Yeah. So, I mean, it's just, I mean, again, I think people are going to use these. And so I'm, hopeful that there's a group of practitioners out there that will guide their patients in using them, because there's kind of two approaches right now. And I'll define my approach that we've just described as the third one. The one approach is just go to the internet and get it. A lot of people are doing that, and there's no program. It's just, you'll meet with a provider every 6 months. And then the other aspect is some of the primary care docs that are adding it on to the regimen of the other patients, of the patient's medications. And again, I don't want to be negative about the primary care docs, because they're busting their butt in the office every day, taking great care of people. I got a lot of friends that are primary care providers, but they usually don't have the means to utilize these medicines for weight loss within a comprehensive program like we've talked about.
Yeah. Okay. I really appreciate that. You mentioned that you pretty much always start with lifestyle interventions, or you start with them and you don't prescribe this. What would be a good example of a situation? Again, I know this is very high level and this is not medical advice, but like, what would be a typical person where you might, like, maybe sooner rather than later, introduce this into their program?
Yeah, I think if their weight or their blood sugar, because again, these medications control blood sugar, is affecting their health already. And they've made an effort with a variety of lifestyle changes, approaches. A lot of times it relates to working through the frustration of a stall. They've lost 15 or 20 pounds, they've done great, and now they're still staying with the program. They're doing everything they can, and they're frustrated. They got another 40, 60 pounds to lose. That would be a common situation that I use them. But I don't know if, so your listeners understand how these medications are used. It's a once weekly injection that's titrated up over a period of months. Start a low dose month 1, move to another dose month 2, another dose month 3, another dose month 4, up to 5 or 6 months. And so what I do is I use lower doses, and I try and keep everybody at a lower dose. Most of my patients are at about half the maximum dose on this, the patients that I treat, which is a minority of my patient population. Um, and we get them up to a certain level, and we don't go higher. And then we start talking about what is the plan for coming down. It's like, since you're in Utah, it's the Stephen Covey thing, who is from Utah. Stephen Covey, the 7 habits of, what is it? 7 habits of highly effective
Yeah.
people.
Yep. Nailed it.
Yeah. So I know he's from out there, and I read his book 25 years ago. And one of his comments, one of his rules that always stuck with me was begin with the end in mind. Okay. So if you're going to start this medication, begin with the end in mind. And the end in mind is to get off the medication. And the end in mind also is to maintain or build your muscle mass, which means you have to be 100%. You have to be strength training and getting adequate protein if you're on these medicines. If not, you're going to lose significant muscle mass. And then you need to prepare for the day when you come off, and avoid that weight regain. And the patients that I've had that have been on the medicine low doses and then off it, their lifestyle has changed and they've been able to maintain their lower weights, but it's only because they're doing all the other things that they need to do to stay there.
That makes sense. So that's why you're not seeing the regain that you're seeing with other people. Not only is it a lower dose, it's a temporary plan at the very least, but they're doing other things to avoid that muscle wasting effect that we're seeing.
Yeah. Yeah, and you gave an intro that was appropriate. It's like everybody's always looking for the magic pill here. This literally is being viewed by some people as the magic pill. It's a magic shot right now, but the pills are coming here in the next couple of years of the same type of medicine. There is no magic pill. You're always going to be giving up something here, and in this case, it's the muscle mass and the weight regain. And then, I don't have a problem with a lot of my patients with side effects, but if you read, about the nausea and vomiting and the potential risk of those side effects, I keep my patients at lower doses, so I really don't have a lot of issues related to
Okay,
that.
good to know. That's great. The normal recommendations for when somebody should start this. I believe it's a BMI of over, I think, 30 without comorbidities. I know the American Pediatrics Association is now recommending if a child is showing signs of obesity at age 12, they can be prescribed. How are you feeling in general about like these kind of like preliminary cutoffs? Do you think they're strict enough, not quite strict enough? What is your personal opinion about that?
So there are two sides of that. I think the BMI of 30 is fine. 27 with comorbidities. Sometimes I see patients that, come to me and they've had like a little bit of a high cholesterol and a BMI of 27 and a half. I discourage them from using the medicines. I have not used it in pediatric patients. Though I think that's coming. I think anybody that does that needs to be really, really careful about not taking a 12-year-old and putting them on medicine for the next, 80 years or whatever. So with that age group, it's going to be critical that they begin to understand the lifestyle considerations. So I'm not treating any pediatric patients. Quite honestly, I've had 19 and 20-year-olds that I've treated with just all I did for 5 years was the CGM, low carb, intermittent fasting, strength training approach. And I had a 19-year-old that lost 60 pounds,
Wow.
went from 270 to 210. So it can be done. So you got to be careful. The medicine, it can be effective, but it's a crutch. And just like if you sprain your ankle, you need a crutch for a while, but you want to be able to throw it away at some point.
Yeah, I love that. We don't have to worry about the kiddos so much because now at age 13, they're recommending that they can get gastric bypass surgery. So if the Ozempic doesn't work for a year and they're going to be on it for the rest of their life, at least we can forever change their intestines. So if we've got that, you just need to wait 12 months.
I mean, and I also have patients that are on this medicine and they stall on the medicine. It's like, you got to do more. I do have some patients where, they want to take the medicine and figure everything else will take care of itself. So you got to stay on it and they get frustrated. It's like, you are not going to move the dial. There are some people, not my patients, because I don't use maximal doses, but there are patients on maximal doses and they still aren't losing the weight they want.
Wow.
Because it doesn't work by itself.
Yeah. The muscle thing is so important. We're now seeing the pictures of like the face kind of sagging on some people that have been taking it for a little bit longer. I'm going to go back to Low Carb Denver 2023. I think it was the Saturday morning panel. It was basically like 5 or 6 cardiologists that all presented one after the other. It was mind blowing, dude. It's so good. And then they do a panel and all of them sit there and they're taking questions from the audience. And I can't remember who the cardiologists were, but one of them was saying like statins are no good for everybody. They don't do any good for anybody. Nobody should be on a statin. Here's the side effects, blah, blah, blah. And right next to him is a cardiologist who is practicing, who says, look, you might be right for a lot of those people. I am in clinic. I am dealing with people. I can tell you that statins have saved lives for some of my patients. Like, they are helpful. And you're right. If the genie's out of the bottle and all of these celebrities are taking it, people are going to take it. And the cost out of pocket is insane, but people will pay it because they're chasing weight loss.
Yeah.
So I think having a nuanced discussion about it is so important.
Yeah. And that's really what we're trying to do. Yeah. I mean, so, the old saying is that, in 20 years, 50% of what you learned in medical school is going to be outdated. You just don't know what 50% it is.
Good.
So
Good luck.
yeah, yeah.
Uh,
So yeah, medicine it's like that. I do think the statins have been way overdone. The focus on LDL cholesterol. I don't think anybody should be started on a statin until they know what their subparticle LDL numbers are, because if you have a favorable subfraction profile, the statins are not going to do you any good. And then there's this issue of, well, statins do raise blood sugar maybe a little bit, and statins can cause cognitive issues as you age. So yeah, you got to be real careful. I'm not completely anti-statin. If I have patients that have high cholesterol, I'll send them to a lipidologist, do their subfractions, and sort that out a little bit. I will tell you, and this, the amazing thing about low carb and keto is people's triglycerides drop like a rock. It's that conversion of blood glucose to fat in the liver. I have patients that have remarkable decreases in triglycerides. They'll go from like 230 to 65. So, there's a give and take here, but you got to be doing a lot of good with that, low carb, high fat diet that lowers people's triglycerides.
Yep. We see that all the time. And it's like the latest Netflix documentary talking about the twin study, and it's all focused on LDL cholesterol. And then it focuses on things that we hardly know anything about, like telomere length and microbiome, all of this stuff that they didn't even measure in the study to begin with. And they ignore all the things we know contribute, like HDL cholesterol, they downplay, triglycerides, they downplay, muscle mass, they downplay. It's so challenging for people to get the right information. It's so easy to keep them thinking all the time about the wrong things. Calories in, calories out, LDL cholesterol, carbs are fine, fat is bad, don't eat saturated fat. It's tough.
Yeah. Yeah. It just things, in the nutrition space and even in just medical practice take forever to change.
Yeah, it does. It does. Well, you're putting out great information in lots of different ways. We mentioned your book. I deliberately did not mention your podcast, which is really well done. You do a great job with the podcast. I would send anybody who is interested in this topic over to your podcast to subscribe, because you guys talk about this all the time and the nuance. Tell us about your podcast. Tell us about what that's been like.
Yeah, it's just Metabolic MD. I'm the Metabolic MD, I guess. And it's just kind of open-ended, just like we're doing here. We talk about all these topics of interest. We sometimes have patients or listeners bring questions to us. I got a great producer that does the podcast with me. And so it's been very, very enjoyable.
I like.
So, hey, can I also make a plug for my practice?
Yeah, of course.
I'm about 90% telemedicine. I'm licensed in Ohio, Indiana, Florida, and Arizona, so I can see patients in any of those states. For those who have not done telemedicine in the past, for this kind of practice that is not really a hands-on physical exam type practice, it's very effective. And so we can do, we can order the CGMs to your local pharmacy. We can do all the labs at your local lab. So if you have listeners out in those areas that I can help, I appreciate them reaching out to Metabolic MDs. I'm also going to mention on the website, you can see I'm doing a Zoom on the medicines, the GLP-1 medicines, on January 30th at 7 p.m. You can go to the website and sign up for that. And we're going to basically, what we talked about with the medicines here was just kind of a mini version of what we're going to talk about for that website. It's going to be mostly questions and answers, so people can get their questions answered. And then the book is on Amazon. Okay, so it's doing really well. It's actually the bestseller for the topic of CGMs on Amazon, so you can find the book there. Thanks for letting me do all those plugs there.
Yeah, of course, man. How proud are you to be able to hold that book in your hand after putting in so much work in your entire career and shifting everything to actually physically hold the book in your hand? What does that feel like?
Yeah, it's fun. I mean, I never had that experience before. I've enjoyed it. I'm probably going to do it again at some point.
I love that. That's great. Well, the great news for the listener is this episode is scheduled to launch on January 29th, the day before you're doing that call. Perfect timing.
Yeah.
We didn't even talk about this beforehand. This is great.
Yeah.
So we'll be sure to link that in the notes to make sure people get that. That sounds like, again, something that's very popular and people want answers to. And yeah, I struggle to think that people are going to get these types of medications without knowing kind of the backstory, but people like you are giving them the nuanced information and again, promoting other lifestyle things that can help. And it's a tool, right? It's another tool that we can use in the tool belt. It's appropriate for some things. It's not appropriate for everything, but if used in the right context for the right amount of time can be very helpful.
Yeah, they need to be used prudently and limitedly.
Yeah,
so
fantastic.
Yeah.
Man, this has been an awesome conversation. One more time, can you tell the listeners where they can go to find you and connect with you and your work?
Sure. So the website, the practice website, again, I'm licensed in Ohio, Indiana, Florida, and Arizona. We see most patients by telemedicine. You can go to Metabolic MDs, METABOLIC MDS.com. I'm on Twitter at Dr. Colo. Also on TikTok, just you'll find me at Dr. Colo. And then we got a YouTube channel as well, and you can find me on LinkedIn and Instagram. So.
Yeah, that's perfect. We'll link to all that in the show notes. Thank you so very much for taking the time to be on your show today. Again, you sent me your book. It's really wonderful, and I really appreciate it. You did a really good job writing everything. So thank you so very much for all the content you brought today, for everything you've learned in your career, and thank you for taking the time to be on our show today. We really appreciate you.
It's been a pleasure. Thanks, Casey.
It's been such an honor. And this has been another episode of Boundless Body Radio. Thank you so very much for continuing to listen to Boundless Body Radio. As 2023 has come to a close and we're starting another new year in 2024, I always try to reflect on not only the direction that we want to go in the future, but also how much we have grown in this last year. Our podcast has now generated well over 400,000 downloads from all over the world, and it's all thanks to fantastic listeners like yourself. I hope you are as excited for the new year as we are around here. The lineup of guests that we have coming up is absolutely staggering, and we're always striving to bring you the best content from the most amazing people in health, nutrition, and wellness. Remember that you can always head on over to our website to book a complimentary 30-minute session with us at myboundlessbody.com. On our homepage, there is a Book Now button where you can select a time to speak with us about your health and fitness plan, especially for the new year. We've absolutely loved chatting with so many of you out there to bounce ideas off each other and try to come up with plans to help you achieve specific goals. And seriously, I really do mean this. Even if it's just to say hello and introduce yourself, we absolutely love connecting with our listeners in the community. Be sure to check out our YouTube channel as well if you want to watch these full interviews and also shorter interviews on more specific topics that are taken from these interviews. We've gotten really great feedback over there, and it's also a really fun way to interact with people who comment. We read and reply to every single YouTube comment we get, so be sure to subscribe to our channel and leave as many comments as you like to keep the conversation going. And of course, if you haven't already, please leave us a 5-star rating and review on Apple Podcasts. It really is the best way to make sure that the podcast gets out to more listeners. Your 5-star ratings and reviews are the best way to support us here at Boundless Body, and to support the podcast at Boundless Body Radio really only takes a moment, and it's very meaningful to us. Cheers to 2024, and thank you again for listening to Boundless Body Radio.